Hello and welcome to our IVF webinar tonight. It's good to be back, and my name is Caroline, and with us today is Dr. Anna. You can see her right there, but please let me know if you can hear me. Hi, Dr. Anna. How are you feeling?
Hello, how are you?
All good. Hope you are well as well.
Good.
Perfect. So this time, as I've mentioned, we are connecting with Barcelona actually, and just let me see. Yes, thank you so much for confirming that you can hear me. And well, we are again gathering here just because we are all in this situation where we are not able to. Most of the time, we are not able to go out because of COVID-19 uncertainty. It's happening to all of us, so we are just simply gathering here so that we can share with you some of the topics, of course, and the doctors are able to explain it to you, but also it is your chance to find out and ask the top fertility experts on any IVF related aspects. And of course, it is all possible thanks to our partners and ambassadors. You can see them all right here on the screen. Some of them, like Andrea Trigo or Dr. Claudia Mika, has already been able to present and of course explain some topics, but there will be plenty more coming. So you can see them right here. Thanks to them, it is all possible. So, and also tonight, as I've already mentioned, we have another topic to tackle, and this one is COVID-19 and pregnancy. And with us today is Dr. Ana Galindo Trias. She is a medical director at Gravida International Center, located in Barcelona, as I have mentioned, and she will start with her presentation, and then she will be able to answer your questions. And as always, remember to type those questions in the chat section so that Dr. Anna can answer them after the presentation. This is, of course, being recorded, so you will be able to again watch it, and you will be able to simply able to just if you need to, of course, rewatch it, you will have a chance to do so. And well, I guess that is all from me, Dr. Anna. It is good to have you here. Are you ready to start our IVF webinar?
Ready. So thank you for your introduction. First of all, I would like to thank this initiative, Stronger Together, because I think at this time nowadays, online initiatives are really helpful for professionals, for everybody to get in touch and try to fight this pandemic together. So today I'm going to focus in what we know that is pretty little, because these pandemics have been just a few months going on. So what we know about COVID-19 and pregnancy. So I will focus in our main characters here. First of all, the virus. What's COVID? COVID stands for this coronavirus disease 2019, and it's the syndrome. It's an acute respiratory syndrome, but the cause of this syndrome is a beta-type coronavirus, which is called SARS-CoV-2. This virus, we've known this coronavirus for a long time. We've known this family of viruses that have this particular shape of a round capsule with little spikes that look like a corona. And when this pandemic started, we looked back and we tried to learn from other epidemics of these similar viruses to learn and to face this new sickness. These previous episodes were caused by other coronavirus. There's more coronavirus that create mild respiratory syndromes. But these are the ones up there, down there, that created severe respiratory syndromes. At SARS 2002, this SARS is the virus that is more similar to the one that we have now. It's an RNA virus. These are all RNA virus, meaning that these little viruses are pretty simple in structure. They have RNA in the middle, and they have proteins surrounding them. The RNA guides their behavior, and the capsule helps them to imbibe, because viruses are not a complete. They are natural parasites to cells themselves. They can't reproduce. They need a cell to reproduce, and they have special appetence for different types of cells. In this particular case, these viruses need cells, specifically from the respiratory tract, to do what they aim, which is reproduce as many copies of themselves as they can. So their main behavior is they go looking for touching to these cells that particularly are more friendly in surface for them, and they invade these cells. They use all this infrastructure of the cell to reproduce and make as many copies of themselves as they can, and then go out and invade another cell. So it themselves are particles that are pretty fragile. But what's the bad thing about these little spots is that when they invade cells, they copy themselves using the resources of the cell, and then they go out and spread. So that's the thing. These two epidemics that we knew about are pretty small compared with the pandemic that we have. So we don't have that many cases to learn about. In this case, first SARS 2002 was located in China and affected around 8,000 patients. And in case of Middle East respiratory syndrome 2012, there were around 2,000 patients affected. We are talking right now in SARS-CoV-2 getting close to 2 million patients affected around the world. So it's pretty big scenario compared with the what we had the scenarios before that we had to learn from. As I said, these little particles have a special appetence for one receptor that is called AC2, that it's mainly located in the respiratory tract, but also could be attached to some intestine cells and could give some symptoms in the intestines. But it's mainly a respiratory virus. As far as I know, there's no evidence of virus in urine samples or in vaginal swabs that primarily have been found. So probably the virus has really specific targets, which are respiratory and maybe intestinal cells. As we all know, this virus initially was zoonotic, so there are many mammals that have coronavirus infections, but right now it's human to human. We know that droplets from infected patients, from coughing, sneezing, talking, they can spread the sickness. Direct contact with contaminated surfaces could be another source of transmission, or even contaminated feces could be, but it's less relevant. We know that, as I said, these little spots are pretty fragile themselves. So if we leave them in surfaces, maybe they can last for a few days, but not forever. The same as in the air. We know that if they are not in these droplets, don't land in another person, and they can invite other cells that are kind of weak. So we know right now how to fight it. We'll talk about later. As I said, it's a pandemic declared officially by the World Health Organization, and it's getting close to 2 million patients affected. What's the symptomatology of this sickness? Mostly it's fever, cough, shortness of breath, sometimes when it gets to moderate, fatigue, body aches, headache sometimes, or diarrhea. These intestinal symptoms are less common. Mostly is air tract what's affected. And medical findings usually is pneumonia, unilateral or bilateral. These are little white spots that you can see in these RX patient are the effect of this infection. And also blood markers altered. If we compare this infection with the flu, the influenza, it's similar, but it's pretty different. The flu hits the body right away, and it's very short term, and it knocks it down or go away. The SARS-CoV-2 is more tricky. It's a tricky virus. It hits the body, as you'll see, first infects and gives this peak of reproducing inside of these cells. But later on, some patients get cured, and that's it. But some specific patients can get this immune burst trying to control this virus that occurs later. When the virus is being more or less controlled, some specific patients, we don't know really the details. We are trying to find out which are going to be these patients that after a first infection where the body tries to beat this virus and the viruses start going down, this the body reacts very heavy, giving a very storm of cytokines, a very high reaction of the immunity that can be causing harm on the own body. So these two curves, first infection, and then when everything is more or less this subacute reaction that doesn't allow the patient to recover, is what concerns the most nowadays in patients that don't really go well at the beginning. As I said, symptoms are similar to the flu, similar to the cold, but not really the same. You see here from Yale New Haven Health, this symptom frequency of cough, fever, fatigue, and shortness of breath that are really the main symptoms of COVID-19. Compared with influenza, which is the flu, you see that shortness of breath is more rare, and with the regular cold, you have more runny nose or sneezing or other kinds of symptoms. So you see here that these are RNA viruses also. They are quite similar, but not the same. They have different behaviors. As you see here, population can really react differently in front of this virus. There's 30% more or less of population that get contagion, that get the virus, and they really react really well to this virus, contain the virus, get immune, and the individual even doesn't feel anything. These are 30% of population, and in this population might be most of children. Children usually are vectors. They can be contagious for a while, but usually don't get any heart symptoms that we can really define. Some can, but most of kids are in this 30%. There's these patients that get the mild or moderate syndromes. In pregnant patients, it's very important to define what's mild and what's moderate, because mild can be nothing to worry about, can stay at home, but moderate starts being a concern. So with moderate, we have to, in pregnant patients, we have to be really aware that we have to take a special care about them. So this is 55% of population, and look, they can be contagious for longer time. They get the virus for a while, they're asymptomatic for maybe 4 to 7 days. Then they get the virus. This is the first part of the sickness, where the virus divides really highly and they invade cells. But in these patients, their immune system reacts really well. They don't burst up these controllers of the infection, and the person gets better little by little. So they get immune and they stop being contagious. There's this few percentage of population, 15%, that they get the infection, they get these symptoms, but they, first of all, they get these symptoms. The virus itself is creating these symptoms, but in another wave, little later, but very close, they can have this burst of immunity that impairs their condition, and they make it harder for the body to get better, because the own system is shutting it down. Trying to kill the virus is killing their own cells. That's the severe patients and the critical patients we're dealing with. And this is about the virus. What's the other main character of our talk is the pregnant women. Pregnant women are two patients in one. We have to take care of women. We have to take care of the little baby that is growing inside. So it's a very special patient, a very special moment in the women's life. So because of this, we are really concerned about maternal and about the baby's status. So first, main concern, or what's the specifics of pregnant women. On one hand, we have pregnant women are pretty young, and we know that the key point for the having severe symptoms, one of the markers for having the severe symptoms is age. So as we are in an age that is pretty favorable, we are pretty confident that these women are going to react pretty well. Otherwise, they have a special immunity. The pregnancy is a stage of 9 months that have specific little changes in immunity, because women are allowing to grow inside a fetus, a kid, that is not exactly like they are. So their immune system has to be pretty friendly or less rigid, because they're allowing to grow this pregnancy inside. This could be a good thing or a bad thing for the pregnant woman facing this virus. We're trying to make up some, trying to decide if this specific immune status of pregnant is going to help or not. We are not pretty sure right now. On the other hand, there's other changes, anatomic changes, that could be at risk, especially in the third trimester. First and second trimester, the anatomical changes are not so fast, but in the third trimester, the belly grows really fast, and everything goes at the top of the abdomen. The uterus is very high, the intestines are very high in the belly, and they are pushing up a little bit the diaphragm, which is the muscle that separates and helps the lungs to move. So pregnant women in third trimester, usually they have less capacity of their lungs to move. So if they get a signal that impairs their respiratory function, they could accuse more these symptoms because of these anatomic changes. So third trimester probably is the one that we are more concerned about the management of the patient because of these anatomic changes. But general topics, we know right now, or we currently, with the data we have right now, we know that nothing indicates that pregnant women can be at more risk to get SARS-CoV-2. We have seen in the population the same percentage of pregnant women that gets this virus. Another subject that concerns us is, are these pregnant women going to have more severe disease? It doesn't look like it, except for this third trimester that have these anatomic changes. And of course, it's not really the evolution of the sickness, is these anatomic changes that makes women express this or suffer this clinic before when they get infected, the shortness of breath or the coughing. Vertical transmission. Vertical transmission stands for the transmission of the virus inside of the uterus, directly from the mother to the baby before this baby is born. There's it's very complicated to know for sure if there's vertical transmission or not of SARS-CoV-2, because from data from China, we've seen that there's a few serious, but there are a few patients where the newborns of COVID pregnant women infected at the time of birth, they were checked, these newborns from these women, and no signs of the viruses have been found. But there's a few reports of newborn where they found a specific immunoglobulin, which is the IgM, against this virus. And this IgM, we know that this specific protein can't cross the placenta. And in these babies, specific babies that were pretty healthy, but they found this IgM in the blood samples of these babies. But on the other hand, they weren't capable of finding the direct virus. So the test that PCR, which is the direct test for the virus, were negative in these newborns. So they didn't find the virus in these newborns, but they found this track of immunity that says that maybe these newborns, when they were inside of their mothers, they reacted to the virus. So still controverted. Most of cases reported don't seem to show vertical transmission, but there's some specific cases that could could lead us to some specific cases that could have had this transmission. Milk, maternal milk, we haven't found particles of this virus in this maternal milk of mothers infected of COVID. But as I said, there's no evidence still because there's still a few cases. Overall, we have to say that these pregnant women are considered at risk of vulnerable population because, as I said, it's 2 patients in 1. So it's very hard to take care of 2 patients in 1 when they have this infection. Better not to have it. We're going to separate the pregnancy in the 3 trimesters and review all these risks that we are concerned about. So first trimester first is 1 to 12 weeks. In this specific trimester is when the baby develop all the major organs. There's the surrounding of the baby starts building the placenta, which is the main organ that's going to feed and allow the baby to breathe, and the heartbeat starts. So it's a very sensitive stage. And what are we worried about in this stage? About miscarriage and about major malformations mainly, because some viruses not reported in COVID, but it's a few months of experience yet can lead to major malformation. As far as we know, there's just a few data or no data available. What we know about SARS and MERS, MERS was a very devastating syndrome. MERS is this similar syndrome that we had before coronavirus, but slightly different. And in MERS epidemics, there was a higher miscarriage rate in pregnant patients that got the virus in the first trimester, compared with the SARS syndrome, which is the virus that is more similar to the one that we have now, where this miscarriage rate was a little higher, but not that much. If we compared MERS and SARS, that is what we can compare with before. MERS was really, had a higher mortality, had 35% mortality. It was really, really a severe disease compared with SARS, which is the one more similar, the 2002, that had less mortality, more or less similar to the one that we have now. So we should compare more with SARS and with our own data. But our own data are still in the haven. We are in our clinic following all these patients that got pregnant in our fertility clinic from December or a little before, and we are starting following them up. But there's still not data enough. Internationally, we are compilating more and more patients, trying to get together enough evidence to make sure and to assure if miscarriage is a problem or not. That the subjective impression that doesn't look like it. That doesn't look like miscarriage rate is that increased. It might be a little bit more, but not substantially. But again, it's a subjective impression. It's not data supported. And also the major malformations. Major malformations have not been reported yet. As far as we think that vertical transmission is very low at the moment. We can't say null, but it's very low for the data. According to the data that we know nowadays, we can assume that major malformations are not going to be a problem. But as I said, it's a lack of data nowadays. So let's go for the second trimester. Second trimester, 13 to 27 weeks. At this stage, what we have, the final building of the organs, neurological maturation, the hearings and the sight start of the baby. Bone marrow starts producing blood cells, and hair starts to grow all over the baby. So it starts finaling this structure construction of the baby. So what are we worried about in this stage is of structural and more functional malformation, not major, just functional, late miscarriage or preterm delivery, very preterm. What do we know about second trimester and COVID? Very low evidence again. We are still new. We have a few months of follow-up of these patients. So what we know, in theory, subjectively, we think there's no higher risk of congenital malformations, but again, no enough evidence. And also, there's a higher risk of preterm birth. But what's it due to? It's due to the infection itself, or it's due to the medical intervention in severe when we have a severe affected case of maternal infection, and we need to induce the birth in order to take care of both independently. So again, very low evidence, but that's what we have at the moment. Let's go for the first trimester. Third trimester is 28 to 40 weeks. Lungs final development happens. Neurological final maturation. Fetal growth is a trimester where the fetus grows so much and the belly starts pumping out and compresses the thorax. That's what we were talking about before, that the respiratory function changes because all the angles of the body change. So what we are worried about in this stage, about premature membrane rupture, preterm delivery, intrauterine growth restrictions, even obstetrical complications. So at the moment, as we said, there's the vertical transmission that always concerns us so much. Waiting for more data, not demonstrated, but the few cases we know that the fetus could have been in contact with the virus inside of the mother. What happens that mother also builds antibodies against this virus, and these antibodies can be IgM, big molecules, don't pass through the placenta, but also build IgG antibodies, which are specific antibodies against the virus. And these antibodies are warriors that can cross the placenta and protect the baby. So probably the mother builds some immunoglobulins that can help the baby to get along with the infection if it happened that we don't know yet. So for the moment, vertical transmission not demonstrated, but we have several question marks. Transmission during labor not demonstrated, waiting for data. As I said, for the moment, the vaginal swabs have turned negative in infected women. How do we know? Because there's several data. We know that the virus has this AC2 preference to attach these receptors, these proteins, and these proteins are expressed in the respiratory tract, in the intestinal tract, but not so much in the reproductive tract or the urinary tract. So luckily, this virus is pretty severe. It has appetences for specific target tissues, and this protects a little bit the reproductive tract. Increased risk of intrauterine growth restriction. This means the baby doesn't grow enough inside of the mother. We have to think about these mothers that are infected. They have problems with moderate or severe cases, have problems oxygenating all their bodies. So probably this restriction of growth probably comes from the impaired respiratory status of the mother, better than compared with the direct affection of the virus, because probably the virus don't go so easily inside of the uterus, as we said. Increased risk of fetal well-being during intrapartum due to maternal status. Again, a person who has problems with their lungs and has a severe infection or moderate infection could not be able to handle all the extra effort that implies labor. So most of patients in severe circumstances go through C-section and not through vaginal partum, because they could handle these circumstances. Here you have a publication of Lancet paper that reports a few cases, you see here, of newborns born from active COVID infection mothers. And they collected amniotic fluid, cord blood, neonatal throat swab, and breast milk, and all the samples were negative for the direct determination of the viruses. This PCR detects straight away the particles of the virus. So what we said, we need more evidence, but looks like it. Now, treatment of infected patients with pregnant patients and with COVID. Mild disease means I just have a little cough, no reported pneumonia, fever controlled well with medication, paracetamol, etc. They can stay at home, rest, address symptoms. Good hydration, very important for the patients, and home insulation, and strict preventive rules for the rest of the family. In this type of patients, we have very close surveillance. We call them, we be aware that they are okay, they come in for monitoring if necessary. And all the comorbidities in our case, in our hospital, are considered risk factors that might take the patient inside of the hospital to control better the status, or even for treating, because we know that comorbidities are a risk factor for having a more severe sickness. What's the comorbidity? High blood pressure, diabetes, pre-gestational diabetes, or other issues with immunity, other issues with your heart or lungs, like chronic lung diseases. All these patients that are pregnant are considered at risk, and we usually don't have them at home. But all the healthy patients with no risk factors, with mild disease, stay at home with very strict surveillance. So let's go for the moderate. Moderate gives us a sign that, well, it might happen that these patients go from this first phase of invasive virus The virus copies itself, but they might go to the other phase of the burst of immunity, and this phase is pretty complicated in pregnant patients. So we take them to the hospital, we give them oxygen support, and we treat them with drugs or medications that stop the virus to develop, like this. Chloroquine is another, hydroxychloroquine is another medication that stops the virus from developing. They let the chloroquine seems like they don't let the virus to expel all these copies of itself outside, so contains the virus. Antibiotic azithromycin has been combined with chloroquine, with hydroxychloroquine, with a good result. Prophylactic heparin, these patients are resting, they don't move that much, so we have to protect them from thrombosis, and we perform a follow-up, obstetrical follow-up. In severe cases, we have to take them to intensive care unit, mechanical ventilation, add other medications to stop this burst of immunity, like interferon, tocilizumab, or other medications to calm down the immunity, avoid or try to prevent that the own immunity kills the lungs. We try to prevent this in this secondary part, not the first part. First part is dividing virus, then it comes immunity. And sometimes we have to finish the pregnancy, specifically when it's third trimester, we think that the baby is going to be okay and the maternal status is unstable. In these cases, we finish the pregnancy, take care of the baby on one side, and the mother on the other side. So it's easier and it's safer for both. So let's go ahead and talk about breastfeeding. Breastfeeding, it's possible as far as we know. We haven't found for the moment any trace of virus in maternal milk, but the fact of holding the baby very close to the mother can put the baby at risk through these droplets or through these contact with surfaces. So regarding to breastfeeding, it's a good thing to do, but also taking in consideration many things. Status of the mother. If the mother has family around, that it's not isolated. All the consideration about comorbidity and risk factors. And if it goes further and we start breastfeeding, we should decide if we breastfeed directly, having all these barriers like the mask and cleaning hands very carefully, and even skin cleaned before breastfeeding, this special mask that contains the virus for the baby to be safe during the period where the mother is PCR positive. And this stage is when we consider the mother infective. When the PCR in the swabs of the throat is negative, we can consider that the mother is not infective anymore and she can breastfeed the baby normally. Or they can get the pump, extract the milk, and give the milk with all these measures, cleaning all the surfaces with all these preventive measures, and another person of the family not in quarantine give the baby the milk. So there's different types of breastfeeding that we can consider in these patients. Finally, it's better to prevent, of course, better not to get it. We know Pregnant women are considered at-risk patients or vulnerable patients. So stay at home, better prevent, minimize going outside, maintain healthy diet and indoors exercise. Stay hydrated, very important. Your body restores the system, breathing system works better if you are hydrated. So good sleep habits, and avoid smoking, alcohol, drugs. Stay apart from other people that could be contagious. Wash your hands and keep surfaces clean. These are all that we know about COVID and many recommendations. Finally, as conclusions, we need more evidence. This is the fact. We can't assure any of the things that we have said in this webinar. We need more cases. We need to put together all the practitioners that are working with pregnant patients and COVID, put together our data and analyze this data to give statements, to give real recommendations. So, pregnant prevention, the best policy. In case of target symptoms, just stay calm, call your doctor, and follow instructions. That's the best thing to do. It doesn't seem that pregnant women have an increased risk to get infected. It doesn't seem that pregnant women are more likely to have severe symptoms. I would add another little spot, our fertility patients. Fertility patients are patients that have more comorbidity and more age. So if you're a fertility patient, take special care, please. Vertical transmission, very improbable, but we don't still know what's the real probability. Transmission through maternal milk seems to be very improbable. So most of societies, we don't forbid breastfeeding. On the other hand, it's good for the baby. It gives the baby immunity. It's good, but with all the recommendations and taking in very, very careful the status of the mother. Be very careful with this. So that's it. I finish with my presentations saying you are at risk population if you are pregnant. Take care, prevent. And thank you very much for your attention.
Perfect. Thank you so much, Dr. Anna, for your presentation with so much detail on everything on COVID, as well as it can and how it can actually influence the pregnancy. Very informative. Thank you so much for taking your time and explaining this to us. Okay, and of course it is now time for our questions. So we do have some questions ready. Let's get to it then. So here's the first one. I'm wondering if COVID may affect an embryo implantation.
Well, we don't have any data as far as we stopped treatments, as far as we knew that this infection spread all over. But what I'm going to tell you is my guess. My guess is that this virus has a very concrete target, which is the receptors, these AC2 receptors that are located in the respiratory tract or intestinal tract. So my guess is that this virus might not affect directly the embryo implantation by being there. On the other hand, if a woman is in ongoing, if the system of a woman is in an ongoing infection, of course, it's going to be less receptive for this implantation. This is another thing. This general status of women that may impact on the implantation. But I doubt it's going to be directly the virus.
Thank you so much for that question and your, of course, expertise on that, and also your thoughts on that. Yes, it's very important. It's still not really checked, but thank you for your opinion on that as well. And now we have another question. Okay, so do we know if COVID affects the woman's eggs? If I use an egg donor that has had COVID prior to donating eggs, will there be any adverse effect to the egg?
Well, another unknown. Again, I think, and it's my impression, it's not something based on facts, it's just a feeling. Again, I think that probably COVID won't have receptors to attach to the egg. Because COVID, these little spikes that it has are very picky when they get attached to the membrane of one cell, and they are really, really dedicated to respiratory tract and to the intestinal tract. So I doubt that the egg will have these specific receptors for COVID. So, but as far as we don't know, all the clinics probably from now on, we are going to make sure that our donors are not in active infection when they donate the eggs, when we start again treatments. So what does it mean? So testing these donors for immunity and for direct PCR, which is direct test of these donors to make sure that they are not infective during stimulation or during pickup. So probably it's going to be different sampling in different stages of the donation to make sure that these donors are healthy at the moment that they donate. I don't know about the eggs that are stored already, but I can tell you what are probably the all the resources that are going to be put in the future protocols.
Okay, perfect. Thank you so much again for the question, as well as your opinion on that. And well, thank you. Okay, there's another question coming up here. So, are there any special precautions for baby delivery? How to protect from possible infection at the clinic?
Well, if you are right now in our clinics, we have very special care in separating patients who are not infected with patients that are documented as infected, and also in the delivery rooms that are not infected, clean delivery rooms, we perform a really clean up after every delivery to make sure that if a patient didn't know that it has it and she would have it and spread some viruses, it doesn't stay in surfaces because we clean all the surfaces, and it's the protocols that are taken in all the hospitals to make sure of the safety of the patient. So if you don't have symptoms, you haven't been reported as positive, the special precautions are just being with your baby, nothing else. If you are positive for COVID, then you deliver in a special delivery room, and we take special measures to protect the baby, to get this horizontal transmission, not the vertical inside of the uterus, but the horizontal. What's this horizontal transmission? Droplets, surfaces. So cleaning your hands very often, For patients who are positive, wearing the special mask is and also the very specific cleanup of the surfaces and everything that contacts the baby is the best way to go.
Thank you for explaining that to us. And actually, we already have another question right here, quite an interesting one as well. So, can you comment on that? How long should the newborn baby be isolated nowadays from other people, friends, family members, etc., in case to be protected from possible infection?
Well, that's an interesting question. Well, the baby is another vulnerable individual in the society. So nowadays, I would say, for the moment, stay at home with your baby and protect your baby. The baby, while it's breastfeeding, is getting antibodies also from the mother, is being protected. But uh, I would put all the general isolation measurements as far as this baby is at least 6 months old or a little older. But this is just an opinion. Right now, babies have to stay at home and not contact with friends or family.
Okay. Thank you for sharing your opinion as well. Okay. Thank you so much for that question too, because it's definitely something that we are, I guess, wondering. So thanks a lot for that. And next question is here. So you mentioned a raft of possible medication for the pregnant women in case of moderate or severe COVID infection symptoms. What effect do or could these medication have on the unborn baby? Anything you could add on that?
These medications that are used in pregnant women are medications that are considered safe considering risk benefit. So this means that are medications that are not being they don't have evidence of malformations. So we can use them in pregnant women. They are accepted. Of course, they are not the A classification of these medications are considered A to X, considering the risk on the baby. A is the safest medications. X is the forbidden during pregnancy. Usually they are B or C considered medications. So these medications are considered benefit compared with risk. Just give it to the mother. That's why they are not used in mild or other kind risk benefit.
Okay. Excellent. Thank you so much again for the question as well as your answer. And well, this is a question we are wondering about. So, so do you know when IVF treatment will start again in Spain, or do you know what the criteria are for clinics reopening, starting treatment?
Well, we don't really know when we are going to start because we are waiting for government and societies recommendations. We are facing to a plateau and little going down of cases. So we are happy about it and we are looking forward to these recommendations. Hopefully either late May or June we would be able to start, but this is a hope. It's not nothing official. And what are we going to do? Probably we are starting building like testing protocols for patients and for practitioners, for staff of the clinic and for the patients. Why? Because we want to know which patients, well, we want to make sure that the patient is safe when the patient comes to the clinic. So we want to know in the staff of the clinic the status of the workers, which one is being infected and already cured, which one is has not been infected and it's at risk but not infected, or which one can't work because it's in an infective phase of the sickness due to the workers. So we are going to stay home workers if they are infective, and the other ones we will take more strict measures or less strict in terms of their status. In patients, it's going to be the same probably. If the patient is one of these 30% of population that already passed the COVID, the infection, and is already cured, theoretically, it would be safe to go through treatment. If PCR is negative, IgG, which is the marker for cure, is positive, and IgM for the SARS is negative. If the patient is susceptible to get the infection, that would be the thing. Just informing the patient and probably recommending a specific preventive measures for these patients would be the way to go. And also, of course, if they are infective at this time, recommend not to start and wait.
Perfect. Thank you so much. We are definitely waiting to hear some news like this, that everything will be back to normal, at least a bit. So yeah, fingers crossed for that. Thank you for your question too, and helping out with this as well. And we will be finishing very soon, so if you have any questions left, go ahead and type them all in so that Dr. Anna can handle them for you and just help you out a bit as well. So this is your final call for those questions, okay? And let me go to the next question we have. So how often will you test your team and staff and the patients?
Wow, that's a tricky question. So we're building our protocols. Probably the key point is going to be how often we test the susceptible population of patients and staff, because the already immune staff or patients are individuals not to worry about. The susceptible are the ones who are going to be really the key point. In terms of staff, we have still to figure it out. In terms of patients, we have more or less figured it out, testing them right when they start testing for the final test for treatment, when they start treatment, and right before going for pickup, and right before transferring if it's the aim of treatment in cryotransfers or IVF treatments. Mm-hmm. According to donors, it's going to be a little more often the testing to make sure that the donors are out of sickness.
Mm-hmm. So it's still like a work in progress, and we need to
we are working on our protocols. That's what we are working on right now to assure safety for patients, for donors, and also for the staff.
Okay, perfect. Thank you so much again for that question. Very important one for sure, and for helping out. And there is one more question. I guess that will be our last question for tonight. However, if you have any left, go ahead and type them all in now. And this is also interesting. So I have heard that it seems that people in Asia are getting COVID for a second time, which implies that no one is immune. Do you know anything about this?
Well, we know that RIN viruses in general are pretty unstable individuals. So little spots that when they copy themselves they make mistakes pretty often. So these give these viruses a lot of little variability in the copies. Every X copies, they have a little variable. That's why, for example, influenza, which is the flu virus, the cause of the flu, every year we have to build new vaccines because of these little variations. Mainly is the same virus, but these little variations make people sick. So probably COVID is going to be, or SARS is going to act similar. So we know that there's little variations in different areas of Europe detected in the SARS. Main variations, the body that has been in contact with one of the cousins of this virus can react better. That's the my opinion, and also what we know in general, that these minimum variations, if you have been in contact with the cousin, the initial cousin, the next generation virus probably is going to affect you and in less severity. But this has to be confirmed. It has to be, we need to know more about this virus. But probably this virus is going to have little mutations that is going to make us make vaccines and change the vaccines once in a while to be upgraded on these little changes.
Excellent. Thank you so much again. So there are still quite a lot of unknowns. However, I guess, all kinds of researches are done to see how it's going to turn out in the end, of course. And hopefully all will be well very soon as well.
Yeah, we will.
Perfect. Exactly. We need to stay positive for sure.
That's it.
Thank you so much. I guess that was our last question. There are not, and there are none questions left. But I would like to thank you, Dr. Anna, for the presentation, and it was excellent. And for answering all the questions. And I would like you to just see that this is helpful for the patients right here. I have only 3 weeks left till the delivery, so your webinar has helped me a lot. So just want you to see
Happy about it.
that it's very, very, very useful. There's also a message in Spanish. I'm not going to read it. Sorry, I'm not so good at Spanish. You understand it. And thank you again. Very good presentation. There's one more here. And also great lecture and good to hear about COVID. Very little or no clear impact on pregnancy, which may help all of us to reduce our anxiety due to it. Happy that we are able to help a bit. And okay, and that's another one interesting. I'm here for my pregnant sister. I've learned a lot. Thank you. Thank you for joining us in such case. It's really a pleasure to being able to be here with you, Dr. Anna, and to just being able to help out a bit. All right. Is there anything else you would like to add, Dr. Anna?
No, just thank you. Thanks to the organizations, thanks to all the persons that are on the other side of this screen. And hopefully everybody will be safe and stay positive. This will pass.
I agree totally. Nothing else to add. Thank you so much again for joining us tonight. And I just want to remind you that we will be here tomorrow at 6 p.m. UK time and at 8 p.m. UK time. So you can register right now just to save your spot. And there are more topics coming. There are more events coming. So you can choose whichever topic is interesting to you. And thank you so much. Stay safe. And of course, Dr. Anna, once again, it was a pleasure to have you here. And have a good night, everyone. And hope to see you tomorrow as well. Thank you so much. Bye.
Bye.